Hello, this is Angie DeRosa, Senior Editor of Contemporary OBGYN. Next in our video series, we have an interview with Dr. Jan Einarsson, who is our Deputy Editor. He gives us his take on the virtual scientific meeting that took place in July of the Society of Gynecologic Surgeons. In addition to being named Distinguished Surgeon by the Society, Dr. Einarsson also gives us his take on what he found to be the most interesting outcomes and research from that meeting. Take a look at this video and follow us online at contemporaryobgyn.net for more stories like this. Thank you.
The meeting was last month, and it's their 46th annual meeting. The SGS is traditionally, or Society of Gynecologic Surgeons, it's founded more by, I would say, surgeons that are vaginally oriented, doing a lot of vaginal surgery. It used to be called the Vaginal Surgeon Society when it was founded in 1974, but it changed its name to SGS in '82. But I think it's evolved now into all sorts of gynecologic surgical society. But you can still sort of see a little bit, maybe a little bit more of the flavor of the urogynecology, prolapse, incontinence. But there's more and more now laparoscopic surgery being incorporated, and just gynecologic surgery in general. And I think that this meeting kind of showed that even though there's still a lot of the prolapse and incontinence stuff, there's also a lot of advanced laparoscopic surgery, like for endometriosis, which I would say is sort of my primary interest. So maybe what I'm interested in the program are obviously a little bit biased based on, what my clinical interests are. I will say that. But one study, the first study I just want to mention real briefly was, there was a randomized trial on the use of absorbable or delayed absorbable versus permanent suture for sacral Cockpixy, which showed basically that there was no difference in outcomes between the two groups, which I thought was interesting, because traditionally we've usually used permanent sutures for this procedure. Okay. But it appears that probably that the mesh just gets so incorporated into the tissues that using permanent suture is not necessary. And that has some advantages, because if those sutures get eroded through the vagina, you can tell the patient then that if it's delayed absorbable, it's going to go away on its own, as opposed to a permanent suture, you may have to go and remove it. And we actually, in our practice, we stopped, or we converted to delayed absorbable sutures maybe 3 or 4 years ago, and we haven't noticed any difference in our clinical outcome. So it was sort of reassuring, I guess, for us to see that there wasn't a difference in this randomized trial. There had been some other studies, but they were cohort studies or retrospective studies. So I thought that was pretty interesting, and maybe that's gonna evolve more into that being what most people are going to be using moving forward, especially after this study. There was another study looking at patient interest and preferences for same-day discharge after a minimally invasive hysterectomy. And so what they basically found is that the majority of the women seem to be in favor of going home the same day. And this is in line with, I think, what I've noticed in my practice also, is that most women do feel comfortable going home the same day, and that seems to be safe. Our readmission risk rate has been very low, and this study again seems to indicate that the patients also are happy with going home. I will say, I think, at our hospital, and this may be similar in other practices, but when I started operating at the Brigham in 2000, or about 14 years ago. I guess it was 2000, 2006, 2007. If you stayed overnight, then you would stay like in a nice private room. But now that insurance coverage has gone down, if you're staying overnight, you're basically staying sort of behind a curtain. So you were kind of downgraded from a hotel to a hostel, basically, in terms of your accommodations. And I think patients probably would just rather go home, honestly, than to stay behind a curtain with multiple other patients next to them.
Yes.
But yeah, but I think it was, I've often wondered if the patients actually would want to go home the same day or not. And I mean, that's been my impression, but it's nice to see that confirmed in a study like that. The third thing that I was very interested in, that was a video, which was a cadaveric study on the anatomy of the, the video is called Beyond the Presacral Space, Clinical Relevance to Sacral Cockpixy Procedures. And what they were really looking at was the sacral nerve roots and the piriformis fascia and the piriformis muscle, which is an area that gynecologists don't generally dwell into because it's very deep, and usually you have no business going there with the procedures we're doing. However, it is clinically relevant for what we do because it is an area that occasionally you can have a tumor in, either a malignant tumor or endometriosis, or it can be relevant to sacral cockpixy or any kind of fixation procedures, because those stitches can sometimes be placed close to these nerves or even on them. And I thought that video was really well done because it very nicely laid out the anatomic landmarks, the average sizes of the sacral nerve roots, the distance between the structures in centimeters. So I think, for surgeons that end up needing to go in that area, I think that's a nice kind of a video to look at, because it orients you to an anatomy that you don't necessarily always or may not be completely familiar with, because it's not an area that we go into on a daily basis. And in my practice, because I deal with the deeply infiltrated endometriosis, I do sometimes see patients that have endometriosis involving the sacral nerve roots and or the underlying piriformis muscle. And so having now been working in that area, I can appreciate better that video. I think, 5-10 years ago, I may have thought more like, what is the clinical relevance of this, because we were never really in this space. But it actually turns out that we do sometimes get into that space. So having a clear designation of those, or description of those anatomic landmarks, I think it was really well done, actually.
We could probably get a link to that video as well, Lindsay.
Yeah, if they can, I don't know if they can provide it, SGS, I'm not sure, but or the authors, I'm not sure if they would allow you to do it, but if they can publish it, I think it's really great.
Even,
All we would have, and going through that, the PDF of the program, they link to a lot of, the documents, the posters, the videos, in some cases. So all we would have to do is see, again, through Dr. Einarsson, see if we can get permission for that.
Yeah, because I think that they, we can check with them and see what they do, if they're willing to do it.
You could even use a screenshot on our website and then link out to them so that it still drives traffic, through to them.
Right. Yeah, I think, but I think you have to, in order to see those things, you have to have been registered to the meeting. So you have to log into their site that way. So it's not open to everybody. Yeah.
Okay. We'll see what we can do. Because they have their agreement with OB management.
Exactly.
So
exactly. Yeah, unfortunately, for us, I guess. So you want me to talk about some more studies, or?
Yeah, go ahead. Did you have others on your list? Or?
Yeah, I had a few others. How much time do we have?
Go. Yeah.
Like 45 more minutes.
Yeah,
Oh,
we
well,
we actually we
that's
actually have a total of about 45 minutes. So about till about 12:45, and then what we'll do is we'll edit this
oh, okay.
out.
Got it. All right, cool.
Yep.
Okay, so and then another study, it was actually another video presentation. It was a four-step strategy for robot-assisted abdominal cerclage prior to pregnancy.
Okay.
And I thought it was nicely done, that video. And it interests me because I think, so I've been doing these cerclages for a while, since 2007. I've personally done over 140 of these, and we've looked at our pregnancy outcomes, and they've been excellent, with over 90% of our patients taking home a live, healthy baby, which is really what they obviously women want. And a lot of them, unfortunately, had multiple losses in the past. So there was a randomized trial that was published last year that showed that if you had a failed vaginal cerclage, and if you did either another vaginal cerclage or an abdominal cerclage, the women who had the abdominal cerclage had a significantly better outcome in terms of having a live baby and not a loss of pregnancy.
Wow.
And the number needed to treat was about 4. So you needed to do 4 abdominal cerclages to save 1 pregnancy, which is not a lot.
Okay.
So I really think, like, after that study, the standard of care, in my opinion, has shifted, so that if you've had a failed vaginal cerclage, I think the next procedure really should be an abdominal cerclage. And that should ideally be done laparoscopically or robotically, depending on the surgeon's preference.
Okay.
I don't think that there's much of a difference in terms of outcomes between laparoscopic or robotic. We've published on looking at laparoscopic versus abdominal or through a laparotomy, and there's no difference in outcomes there, and other groups have reported similar findings. So because the laparoscopic approach is less invasive than a big incision, and it's better for the patients, that I think, to me, that should be the preferred approach. So I think that things have moved really slowly forward in this area, and I think for women with cervical insufficiency, if they have had a vaginal cerclage that did not work, that they should definitely have an abdominal cerclage, and that should be placed laparoscopically or robotically if that's the surgeon's choice. But I think also it's important when you do these cases that obviously that the tape or suture be tied very snugly around the cervix. And so there could be a little bit of a learning curve in the first few cases for surgeons. So they just have to pay attention to that, make sure that it's done well. But I see more and more centers doing these cases now across the country.
And is it specific to women with recurrent pregnancy losses?
So these are exclusively for women who have had pregnancy loss because of cervical insufficiency or cervical incompetence. So it's not for if you have an early pregnancy loss or loss because of infection or whatever. It's purely for the women who have it because their cervix isn't able to hold the pregnancy.
Yes.
And sometimes that's because they've had a prior procedure, like a LEAP procedure, for example, for cervical dysplasia, where they have to cut like a little piece of the cervix out.
Yes.
But sometimes women it'll happen without any prior surgeries. It may just be that the structural buildup of the cervix just wasn't for some reason adequate, or it's just not functioning the way it's supposed to. But I think that what I've noticed now is that obviously women are much better informed now because of these online groups, etc. So I see now a lot of patients where they've had a loss and there wasn't time maybe to put a cerclage in.
Okay.
And now they, of course, want to get pregnant again. And then they basically want an abdominal cerclage from the start. They don't want to try a vaginal cerclage. So the study that randomized study was
Yes.
in women who had a prior failed vaginal cerclage. So we don't really know if doing a primary abdominal cerclage is the best option for those women, but it kind of makes sense. And I have a hard time denying that to them. And I think even though it's not maybe based on level 1 evidence, and I find that insurance companies generally will cover it, even though they've not had an abdominal cerclage. I mean, sorry, a failed vaginal cerclage in the past.
Yeah. Okay. And
yeah.
We are looking at, for the January issue, recurrent pregnancy loss.
Okay.
So if there is a tack we could take with that, you know, when it comes to the cervical insufficiency.
Yeah. Okay. Yeah. I mean, that could fit in with that. That's one of many things that can cause it. There's also, you know, immune issues and all sorts of other stuff. That's, but yeah, it's one of the components of it.
Okay.
Let's see. Another study, they were looking at the sort of pre-operative injection of bupivacaine or Marcaine when they were doing pelvic organ prolapse surgery. This was a randomized study. So basically, they randomized the patients into getting the injection of the local anesthetic before the surgery versus placebo. They had actually 3 different groups. One had the dexamethasone as well as the bupivacaine, and one had just bupivacaine and one just got saline. But so the theory is that if you numb these nerves that are sensory nerves from the pelvis before you start doing the surgery, that this will basically result in less pain after the surgery, because it's sort of this preemptive analgesia theory where you're preempting so that there's no pain sensation going up to the nerves as opposed to, or to the brain, as opposed to doing it at the end of the procedure or just relying on the general anesthesia. And this has been done in a lot of other areas as well, including like port sites for laparoscopy. But unfortunately, the sort of science on this is very mixed. And so, for example, this study, they did not find any difference in pain, whether the patients got this, the Marcaine or the local anesthetic before, or not. And so that's, and I've seen the same in other areas where this sort of preemptive analgesia isn't always, doesn't seem to be always effective. And part of the reason could be that patients that have either vaginal surgery or laparoscopic surgery, they generally don't have a lot of pain. So the bar is set very high in terms of their outcomes. Like the outcomes are already really good.
Yes.
So it's kind of hard to improve on that significantly. So you can capture it. And pain is a little complicated because there's a lot of factors that come into it. So there's a kind of a big noise in the sample, so to speak. There's a lot of factors that are influencing the pain and the pain sensation. So you maybe these investigators may have needed a bigger group of patients to find a difference in the signal there. But one of my pet peeves, I find, I see my residents do this sometimes, is that they will inject Marcaine into where they're going to make their incision for a port site, and then they'll make an incision right away in that area. And they think that that's preemptive analgesia, but it really isn't, because Marcaine takes about a minute or 2 to take effect. So if they really wanted to do preemptive analgesia, they would have to inject and then wait for a minute or 2 and then make the incision. But nobody does that. They just make the incision right away. So that's not really preemptive analgesia. Yeah, it's one of my one of the things that I often noticed, and I often mention to them when I'm working with them. All right, we can move on to the next one, I guess.
What was the size of that study, Dr. Einarsson? How many participants?
I actually don't have it in front of me how many participants. It wasn't that large. It was 3 arms. So each arm only, I don't want to guess, maybe 20 or 30 patients in each arm or something like that. Yeah, but I can look into that. There was another study that I thought was interesting on endometriosis. So they basically adopted this policy on patients that had pelvic pain and possible endometriosis to basically take out the appendix routinely, except if the appendix was retrocecal, meaning that it's harder to get to it. It's sort of hidden behind the colon. So if it was easy to remove, they would remove it routinely in all their endometriosis patients. And actually what they found is that about 5.5% of the time, I think, they had endometriosis in the appendix. And in over half of those, there wasn't any endometriosis visible on the surgery. So surgically, the appendix looked fine. So they're basically saying that given that the complication risk of removing the appendix is very low, there were basically no complications in this study, and that's been shown in other studies too, that maybe we should just be removing the appendix routinely in all women that are having endometriosis surgery, given that maybe 5 or 6% of them will have it on their appendix. So which is a fair, I would say, fair kind of a conclusion. But what's missing, I find, in their study is that does it really make a difference in terms of their outcome? So do they, if you do routine appendectomy, does that decrease the risk of endometriosis symptoms, either coming back or being persistent? And that's a little harder to answer. You would have to do like a bigger study to answer that. What I generally do is I'll have a fairly liberal policy of appendectomy. So obviously, if there's endometriosis lesions or suspicious lesions on the appendix, I will remove it. But I also remove it in women who have predominantly right lower quadrant pain. If their symptoms are mostly on the right side where the appendix is, then I'll remove it because I'm trying to be more symptom specific. So, if someone has no pain on the right side, and let's say there's like a microscopic lesion on the appendix, does it really help to remove it? I'm not quite sure. I mean, that's sort of a discussion point that people probably are going to have. And practices probably vary a little bit on this. And then there's another endometriosis study. Again, I'm a little bit biased because I love, or I'm very much into endometriosis surgery. I do a lot of it. And it was a very nice video presentation of the surgical management of diaphragmatic endometriosis from the Cleveland Clinic. And they went sort of systematically through how to do it and what anatomic structures you need to be aware of. And I think it's helpful because for us gynecologists, we're not generally in the thoracic space. That's not, our territory. Yeah. We're sort of, the diaphragm is sort of our border or line in the sand. And so what they do generally is, and we do as well, is to work with the thoracic surgeons. And so we'll do our laparoscopy, and the thoracic surgeons will do their video-assisted thoracoscopy. So put a camera into the thoracic cavity to make sure that there's no endometriosis in the lung or higher up in the thoracic cavity. So, but I thought it was a nice video showing sort of, again, the anatomic structures that we as gynecologists may be not always familiar with. There was another, I would say, a theme or that I noticed is that in general in gynecologic surgery, robots have become or are already predominant, but that seems to sort of progressing. So Intuitive obviously has been sort of the market leader for a long time. And then recently we have another robot that's FDA approved and is being used in the US, which is called the Senhance robot. They were showing, there's another company called Mimic that was showing their transvaginal robot. It's called Hominis or Ominis, Hominis. And that's different because it basically, the access of that is through the vagina. And so it's very different from the other offerings. It's not FDA approved yet, but it is being used has been used in Europe and They've done hysterectomies and other surgeries with that. So I thought that was a kind of an interesting approach to robotic surgery, and maybe will help surgeons that are predominantly doing the vaginal approach to their pelvic surgery, to kind of broaden the application of their cases. They are doing it though with laparoscopic assistance, so they put one camera in the belly button to make sure when they're putting the robot in through, they've actually put the robot through the posterior cul-de-sac, so between the uterus and the rectum, and it's not a huge space to put that in, so you have to do that under direct vision so you don't have any injury as you're introducing the robot. But I think that's a promising technology. And we'll also see other players enter the robotic surgery market in the next few years. And so it's going to change quite a bit, I think. And Medtronic, for example, has been developing their robot for a while, and there's Titan Medical and others that are going to bring in others. So it's kind of an interesting segment of the surgical field that, you know, it's probably going to continue to evolve. But there's always that rub between technology and cost. So
yes,
I think that's been one of the issues with the intuitive robot, is that it has added cost to a lot of procedures. Even though a lot of surgeons do like it and they do a good job with it, it tends to prolong surgical time sometimes, and it may add cost to, especially if you're doing, you know, fairly straightforward surgeries like a hysterectomy or something that doesn't really need a lot of technology necessarily. So it's kind of like driving a Ferrari to work when you can just take your Toyota or something like that. There's been a lot of debates about that in the past. It used to be kind of a hot button issue initially when the intuitive robot came onto the market. People have just they've kind of stopped arguing and just started doing whatever they like to do. So the people who like the robot just use the robot. The people who don't just use regular laparoscopy, and they just leave each other alone. But it may be time to maybe kind of resurrect that maybe a little bit.
So is that related to the first in human clinical trial of the new robot-assisted surgical system?
Exactly. Which seems, I mean, that seems like it seems a reasonable option. Obviously, that's a first trial, and so there's a learning curve, and the surgeons are still learning to use it. So it's gonna take a little time to get to routine use, you know, where people are really adapt to using it. I mean, I think it seems like a interesting approach and could be useful. Another tool and toolbox, you know, for the surgeon. And then another theme I think that I've noticed is that now we have radiofrequency ablation of uterine fibroids. So we have now 2 systems that are FDA approved and available.
Okay.
One is laparoscopic. So there's a laparoscopic system, which is the Accessa system, and then there's now a transvaginal system, which is the Sonata system, and the Accessa system is maybe more geared towards subserosal fibers, or big fibers that are sort of more inside the abdominal cavity, as opposed to the Sonata is more for fibers that are closer to the uterine cavity, and maybe more for women who have abnormal bleeding, while the other is more for women with bulk symptoms, although there's definitely some overlap there. Anyway, it's just interesting because now we have more treatment options, again, more tools in the toolbox. Both approaches appear to be promising. But I think, you know, again, I mentioned all the robots. Now we have these radiofrequency options, and there's also all these other tools I haven't even mentioned yet that have been sort of coming out. So a general theme in surgery is that we're getting more and more things that you have to familiarize yourself with and be comfortable with. And I think it's becoming increasingly difficult, if you're not a high volume surgeon, to really keep up with all of this and to be adequately trained and to be adequately sort of comfortable offering, you know, these things to patients. A lot of surgeons today are, you know, that are not subspecialized. I think they are struggling a little bit because they don't have, again, the volume to do these cases, because they have to learn. It's a new technology, new way of doing it, and if you're not doing a bunch of cases a week or a month, then it's hard to learn, and then you may not be able to offer that, to your patients. I think what's happening really is that a lot of these surgeries are moving now to the subspecialists. So the urogynecologists are doing a lot of the incontinence and prolapse procedures, and the minimally invasive gynecologic surgeons, such as myself, are doing more and more of these, surgeries for endometriosis and fibroids, and and maybe sort of the OBGYN specialists that have not done fellowship training or subspecialization training, I think are having a little bit of a hard time now in terms of getting surgical volumes. Because it's not like what used to be 20 years ago, where we just had like, either you did a big incision or a laparotomy, or you did a vaginal surgery or hysteroscopy. Now you have all these different robots and different technology and laparoscopic this and that, and it's hard to keep up, I think, if you're not doing a lot of volume. Speaking of that, there are now these kits now that I noticed, it's another theme, is for apical suspension, vaginal apical suspension, or sacrospinous ligament fixation. There was the Einarsson device and the FemSelect. They're trying to get away from using mesh, because mesh has been associated with significant complications, especially for vaginal suspensions. So I think we'll see more, also in the future, more devices and kits for prolapse surgery and maybe for incontinence surgery, where mesh is not the primary method, because of the concerns, both medical legal concerns, but also patient concerns about the use of mesh for pelvic prolapse surgery.